is Professor Alkis Psaltis from Adelaide University, South Australia. So nice to have you with us, Alki. And Professor Psaltis will talk on the current role of surgery in the treatment of CRS. Thank you very much, Alki. You can start your presentation.
Terrific. Thank you, Tim. Thanks for the very kind invite. It's always good to be speaking in front of a Greek audience, as well as obviously the rest of the world. So Tim asked me to speak about updates in chronic rhinosinusitis, and particularly with the role of surgery. And we know that surgery, although it changed significantly sort of 20 years ago, 20 to 30 years ago with the advent of the endoscope, it probably hasn't changed too much in the past 10 years. So in terms of the talk, these are my disclosures. None of them are relevant to the content that I'll be presenting today. So in summary, I'd really like to focus on sort of these three areas. Does sinus surgery work? What do we know about outcomes? What evidence do we have for surgery? Why and when does it not work, which we all can attest to in our own patient cohort? And how can we make it better, in particular to the extent and the timing of surgery? And this really complements a lot of what the previous speakers, in particular John, has spoken about in terms of topical therapies. So if we look at the timeline of surgery, we have come a long way since its inception. We've gone from these external incisions, which never really produced good long-term outcomes and created scars and morbidity, to endonasal procedures where we used a headlight to pluck polyps out and perform headlight ethmoidectomies, to endoscopic surgery, which simply punctured holes into the sinuses, such as inferior meatal antrostomies. And obviously when Professor Mesenklinger and Heinz Steinberger came along, the whole concept of endoscopic surgery was turned on its head. And we started to think of surgery as functional endoscopic sinus surgery. And this really was based upon their anatomical studies and their histological and physiological studies of how cilia beat. And we realized that the reason why surgery wasn't working was because we weren't opening the natural pathways of where the sinuses outflow to. So as a consequence of this, these surgeons really started bringing in the concept of surgery is more than just making holes. It's to clear and facilitate drainage towards the natural ostia. And probably for the sort of the 15 to 20 years after the functional endoscopic technique was perpetuated, this really was the role that we had for surgery. But then in the last 10 years, we've had the thinkers that have come along. And what's happened is that we don't really look at surgery as the cure or the treatment for sinusitis. As we've understood the concept of what sinusitis is and the pathophysiological mechanisms of sinusitis, we've started to really relook at the role of surgery and how we can make surgery more successful through our understanding of the biologic and pathophysiological process that's occurring. So the role of surgery has gone from us telling patients that we're going to cure them to telling them that we're going to manage them. It's no longer simply improving drainage and ventilation, as was sort of perpetuated in the early functional endoscopic surgical days. But now it's, as John said beautifully in the previous talk, it's to reduce inflammatory burden. Intraoperatively, at the time of surgery, which is just as important as post-operatively, and I'll present some data on this. These are the two key roles of sinus surgery in terms of managing the inflammatory load of these patients. So if we look at outcomes of endoscopic sinus surgery, I really think this recent publication, published in 2020 by Richard Orlandi's group, really does summarize this topic really well with really easy to understand evidence-based recommendations. Now, in this study, they looked at the outcomes of sinus surgery as determined by quality outcomes, how satisfied our patients were with the outcomes, and whether or not the costs justified the surgery. And what they did was summarize the high-level evidence that had been published in the last decade. They found that, yes, there is definitely good evidence to support surgery in terms of improving quality of life, endoscopic scores, and overall productivity of patients. And Solar, who was quoted in this paper, demonstrated that the SNOT-22 scores, which is our validated way of obviously assessing patient symptomatic improvement, had an improvement about 24 in all of the studies, which was much higher than the minimum clinical difference of 9. And this improvement really did persist for up to 10 months. Now, there have been studies beyond this that have shown that surgery and patients report an improvement, 75% of patients, up to about 10 years post-surgery. So surgery is really robust in terms of long-term outcome. In terms of patient satisfaction, this is difficult to assess because there are so many subjective and confounding factors that come into how a patient perceives success. But this study, which looked at patients' expectations, showed that success correlates to how much they had an improvement in their symptom scores, not necessarily whether or not it related to if they achieved the minimum clinical difference. And of most importance, and the most important predictors of success and satisfaction, was whether or not the patient had had their pre-operative expectations met. So did they have appropriate counseling before undergoing a sinus surgical procedure as to what could be achieved? And was their number one symptom, their most important symptom, addressed by surgery? And if these two features were addressed, these patients reported really high satisfaction from surgery. Now, if you looked at the whole group of patients that were assessed, and this was over 100 patients, 83% of these patients believed that surgery improved the symptoms. Importantly, 86% would have surgery again, and 94% would recommend it to others, which really is I suppose, a really useful statement when we're looking at whether or not patients are satisfied by undergoing such an invasive procedure. Now, if we look at costs, there are lots of costs that come into determining the cost of something. And we obviously know that the direct costs of sinus surgery are initially higher than medical treatments. But with time, surgery reduces the indirect costs significantly in patients with very severe chronic rhinosinusitis. And I'd like to take you through this flow diagram, which summarizes this information. So in patients who have mild phenotype, so less effect on their quality of life, i.e. about 6 days off work a year, if you continue them on medical therapy alone, at the end of the treatment, they will still have 3 to 6 days off work a year. If we look at the patients who have very severe phenotypes, these are the patients who are spending almost a month off work with loss of productivity a year, and you continue medical therapy alone in this group, they really don't get significant improvement in the number of days they take off work. They still have a fairly poor quality of life and function. However, if you compare that same group and you do surgery on those patients who are taking that much time off work, you can get them down to the level of a patient who is a mild phenotype, which really does suggest that surgery for this particular cohort of patients does have a significant advantage over simply persisting with medical treatments. And in the long term, will increase productivity of these patients and reduce the indirect cost to society. So this brings us on to, can we improve surgical outcomes? And there are so many quotes out there that we can all attest to that we learn best from our failures. And when we fail a case or when a patient doesn't do well, they're the cases that we really need to be thinking more about so that we can improve the outcomes. Now, I'm not a huge fan of anything that comes out of Donald Trump's mouth, but I think this is probably a quote that we can say is useful. It's probably better to learn from other people's mistakes and attend courses like this one here, rather than your own, because it's a lot cheaper and it probably causes a lot less morbidity to our patients during our learning curve. So why does sinus surgery fail? Well, there are two main reasons. They can be classified as technical failures, where the surgery has not achieved what it's meant to achieve. And then we have the disease failures. And these are failures where surgery's been done well. The sinuses have been opened up, the ostia are large, but we have persistent disease despite what we would call well-performed surgery. If we look at the surgical failures, these come down to various factors. So old school teaching of just simply open the ethmoids and the rest of the sinuses will take care of themselves. If we don't treat the tissues with respect and we strip mucosa, they heal poorly. But also there's a huge learning curve with surgery. And so if we start with the most difficult cases, on our learning curve, we're most likely to get more failures than if we started with easier cases, learned how to use the instruments correctly, how to handle tissues, how to predict anatomy, and then progressed to the more difficult cases. So here are some surgical failures. This is where a surgeon performs centripetal surgery. It's like doing a polypectomy with an endoscope rather than a headlight. And what we can see in this particular case, this patient simply had the ethmoid and the maxillary addressed. And this is what they look when they go to the revision surgery: ongoing inflammation, the maxillary stenosis, and all that polypoid inflammation in the ethmoid has come back. Another case of surgical failure. This is where you don't address the natural os. And as a consequence, you get this recirculation occurring between the natural and the surgically created or accessory os. This is another case where we haven't understood the anatomy properly. There's an anode cell. The surgeons thought that they've opened the sphenoid nice and widely, but the patient still has a persistent postnasal drip. And the reason for this is that although the sphenoid, the anode cell has been opened up, the natural os, which is sitting medial to the superior turbinate, remains unopened. So we can see this recirculation between the natural os and the sphenoid sinus. So again, we haven't addressed the functional unit of that sinus, and the symptoms persist despite the scope looking pretty good in that posterior ethmoid cell. Another failure is the retention of these cells, these Haller cells. And obviously these Haller cells, which pneumatize into the maxillary sinus, can compromise the outflow tract and should be addressed at the time of the procedure to maximize that diameter. Now, this has been summarized in two really nice papers, one in 2004 and one more recently in 2013, which listed all the anatomical reasons for failures. So the other reason for technical failures is that not all sinuses are the same, and this is particularly the case for the frontal sinus. And if we look here, we can see that all of these frontal sinuses are different. They have different pneumatization of cells into the sinuses, and they have different AP diameters. And we can see that this sinus, which has no cells pneumatizing above the beak, is probably the most complex of all the sinuses. So if we don't have a system to grade the difficulty of sinuses, and we just take on all sinuses as they come through the doors without really having gone through the learning curve, we are going to get more failures. And for this reason, a group of us around the world got together to form a classification system for the complexity of frontal recess and frontal sinus surgery, to really provide mentors a way of graduating the trainees in their sinus surgical approaches. And really what we did when we did this study was to look at the frontal sinus, which is really the one that fails most in most people's hands, and particularly in juniors' hands. And what we found out from this consensus statement was that really there are two factors that determine the difficulty of a frontal sinus. One is the diameter of the frontal sinus, and the second is the pneumatization of cells into the frontal sinus. So when we're starting frontal sinus surgery, we really should be taking on wide AP diameters, greater than a centimeter, with no cells going into the sinus. We get our confidence of using angle instruments and angled scopes and of mucosal handling without stripping. The cases which are the hardest are the patients who have very narrow diameters, where you can barely fit an instrument up into the sinus. And in these particular cases, if you've got cells pneumatizing into this sinus, it makes it very difficult. And they're likely to fail even in the best hands, but particularly in those on the early learning part of their learning curve trajectory. So now let's look at the next group. And these are the disease failures. These are the patients where you think you do well surgery, and then they come back 6, 12 months later and they're failing. And these are the patients that are most frustrating. What all these patients have in common is that they have a high disease burden, whether it be biofilms, fungus, exotoxins, osteitis, or eosinophilic mucus. The common feature is the high inflammatory burden. And what we do know from the evidence is that the higher the tissue eosinophil count, the higher the peripheral blood eosinophil count, the worse these patients are in terms of their disease preoperatively, and the worse these patients do post-operatively in terms of outcomes. The higher the eosinophil load, the worse the outcome post-surgery, particularly if we're not managing them with medications long-term. And so why is this the case? Well, it's the case because the eosinophil is a really powerful cell. It has multiple functions. It not only presents the antigens and elaborates the inflammatory cytokines, but it can attract more and more eosinophils to magnify this response. And with time, we get release of factors from the eosinophils, such as eotaxin and eosinophilic cationic proteins, which causes tissue injury and tissue remodeling. And I suppose the beauty of the eosinophil is the ability to create this autocrine persistence of inflammation due to the attraction of more and more eosinophils. And so with time, these patients develop more and more inflammation. So I'd like to introduce two concepts here, the inflammatory load hypothesis and the irreversible disease hypothesis, which really, I think, is the advancement of how we've understood surgery. So if we look at the inflammatory load hypothesis, we should look at our aims of surgery, which is to try to reduce as much of that inflammation as at the time of surgery, and then also increase the access for post-operative topical medications to reduce the inflammation and keep it at bay post-operatively. And with the advent of biologics, we now have a systemic medication which we can give long-term without the same side effects of prednisolone or corticosteroids. So we have a new arm, which obviously Professor Backhart will talk about next. So when we look at these three sinuses, look at the maxillary sinus, they have different extent of disease. Should we be doing the same extent of surgery in all of these cases? Well, the reality is no. In that first case with mild osteomeatal unit disease, all we really simply need to do is open up the osteomeatal complex and then sometimes not even extend that osteomeatal or the antrostomy any further, because as John said, 4 millimeters is all we need for topical penetration. With the second case, where we're starting to get more mucosal thickening, we've got a higher inflammatory burden. And in these patients, we really need to be extending that antrostomy posteriorly, right back to the posterior maxillary wall, and also down to the inferior turbinate. And this is so that two things can happen. We can get our angled instruments in there and suck out all of that pus that's containing a lot of the inflammation. But also, the larger we make that antrostomy, the more topical irrigation will go into that sinus. And I'll present some literature onto that a little bit better. Now, let's look at that last group. Do we simply do the surgery that we did in that second group? Well, that's what we did in this particular patient. And you can say that within 6 months, the disease has come back. And that's despite the patient being on topical corticosteroids. And why is that the case? Well, this patient has a high inflammatory load. We also have patients in the same group who have poor mucociliary clearance, such as cystic fibrosis, irreversible disease, who will suffer a similar fate. So when we look at how much disease we can get out, with the 30-degree endoscope and angled instruments and a standard antrostomy, we can probably access about 30 to 40% of that sinus. If we use a 70-degree scope and we start using malleable instruments, studies have shown that we can access between 40 to 60% of the sinus. But that leaves about 40% of that sinus with ongoing inflammation within the depths. And with time, all those eosinophils that we've left behind and the primed T cells will perpetuate the inflammation that has occurred in this particular patient, where we've got a wide open antrostomy, but ongoing disease. So there's ways, obviously, that we can get the disease out through more extended approaches. And we can look at the canine fossa technique, which is a technique that Professor Wormold popularized, where we can make an antral window, we can get a debrider into the sinus, and then we can shave up as much of that polyp as possible. And this really is to try to get rid of as much of that inflammatory load as possible, which will then allow the topical antibiotics to do, the topical steroids to do the rest. Obviously, there is evidence to support this. And in these two particular studies, 80% of these patients had good long-term outcomes in terms of their surgery. And these included Psaltis-tried patients who obviously have the highest load of disease. But these procedures are associated with some facial numbness and some swelling in between 1 to 5% of patients. And really, that's not a complication that today's patient really wants to suffer from. So this has led really to the popularization of the extended antrostomy, which involves resecting the middle third of the turbinate and that lateral nasal wall and extending it anteriorly up to the front face of the maxillary sinus. And we can see in this particular patient who's got really bad disease, this technique is the only way that you can get out as much of that inflammation as possible. And this really involves getting the resecting the mid third of the turbinate, preserving as much of that head as possible, resecting if that's for a humidification of the nose, resecting the mid-third of that of the lateral nasal wall, and then using angled instruments to scoop out as much of that fungus as possible. And you can see here that with fashioned flaps that we've got going on here, we can actually protect and cover the exposed bone, so we get much less crusting than we would ordinarily in a standard case if we didn't create those flaps. The medial wall of that maxillary sinus is quite thin. It can be easily broken through with the freer once it's been exposed. And then you can see all of this thick inflammatory tissue can be removed with instruments. And you want to spend as much time as possible getting out this thick eosinophilic and fungal mucin. And this is that same patient who ended up having a CT for some reason down the track and then presented to me to show me the CT, absolutely no disease whatsoever. And this is how they look post-operatively, a really healthy maxillary sinus. Now, we've got a study that I did when I was at Stanford that followed up these patients from 2008 to 2013, and the results spoke for themselves. After 7 years, the vast majority remained really good, and there were no patients that got worse. And we've published on this, which shows that the more extensive surgery you do, the bigger the antrostomy, the better the access to different instruments, the more you can clear the disease, and we simulated disease in these patients, and the more you can get irrigations into the sinuses. So let's look at the frontal sinus. Now, this is a patient who saw me that had 10 previous procedures prior to seeing me. And these are the scans that were taken over the course of those years. And the surgeon did the same surgery each time. And you can see they've done a fairly good procedure other than perhaps removing the top of the supraagar cell and the suprabular cell. The surgery is pretty good, but this patient ended up having surgery every year. And the reason for this was that frontal sinus probably wasn't being addressed. So it acted as a reservoir for more and more disease to persist. And this was a patient when they presented, they had these thick polyps everywhere. Now, with an appropriate procedure, such as the frontal drill out procedure, this was done very early on in my career, and you can see that the frontal drill out cavity is not as wide as I would like it now. But even with that procedure, this patient has done really well. Now, this patient had some facial pain a year after the procedure. And so the GP immediately did a CT, because that's what they did in the past, thinking that it would be the sinuses. And you can see that the sinuses look pristine in this particular case, simply by maximizing the opening so that we could get out that inflammatory load. But more importantly, those topical steroids could continue to work by penetrating into those sinuses. Now, for the interest of time, I won't go through a similar case. This was another patient who had very similar disease and had a standard fess at the beginning. And you can see when they came and saw me, they had all these polyps growing again. And again, this patient, 5 years after their procedure, has had a really good outcome. They've still got a bit of granulation tissue, probably a little bit of bone exposed over the T, but you can see that's the big frontal drill out cavity we like to see, where we've lowered down the frontal T right to the skull base. And again, despite having really bad disease, with topical steroid medications and appropriate wide bore surgery, they've done really well. The sphenoid sinus should be treated the same way. We've got good evidence to show that the sphenoid sinus stenoses by about 50% in the first 12 weeks. And so if you're going to open the sphenoid sinus, open it maximally. And whatever you do, don't strip the mucosa, because this is what can happen in this patient who had no sinus disease prior, ended up having stripping of the mucosa and created this thick osteotic reaction. In this particular patient, we had to do a sphenoid drill out, for which in the interest of time, I'm not going to go into too much detail. As was alluded to by John, management of the middle turbinate is important. I think more and more of us are resecting the middle turbinate or part of the middle turbinate in the refractory polyp cases, or if it's polypoid, because if it does become polypoid and doesn't allow access to post-operative medications, these patients will fail surgery. This is a patient who's got central allergy syndrome, which John really is the world expert on. And you can see that if we simply left this turbinate and tried to work around it, this patient's going to fail probably through lack of irrigation getting to those sinuses. So we've resected the concha bullosa in this case, and we've stitched the middle turbinate to the septum. I also, if we've got a lateralized turbinate, I'll resect it, because if it's lateralized once, it's going to lateralize again, and you're going to get failure. So we resect that turbinate, leaving probably just a superior third of it. Be careful not to get a CSF leak when you resect it. And then we can access those sinuses post-operatively with the microdebrider, so we can reduce that inflammatory load. And we can also obviously increase penetration to those sinuses post-surgically. So really, I want to speak about this last concept of the irreversible disease hypothesis. And this is really with the timing of surgery. And what we've known from the lower respiratory tract is that if we don't treat an asthmatic aggressively and consistently on a daily basis, with time, they'll go from an airway that responds to vasodilators to an airway that doesn't. That becomes an irreversible airway that essentially deems them a respiratory cripple. And because of that understanding, the guidelines for the treatment of asthma have changed. And they changed in 1997 from only treating patients with daily inhaled corticosteroids if they had moderate symptoms to treating them on a daily basis if they have mild persistent symptoms. And the same can be said in the sinuses. We don't want to leave the patients to the point of getting this irreversible disease. And this is my last slide, which really talks about the timing of surgery. And I think this excellent study by Valerie Lund and Claire Hopkins and Joe Rimmer shows that if we wait too long to operate on these patients are less likely to get an improvement from surgery, and they're less likely to maintain that improvement from surgery. So if we wait for 5 years, these patients will have irreversible disease changes that will make them less responsive to surgery. So really, the take-home messages are the extent of surgery should be determined by the disease load, not by the surgeon. Long-term maintenance with topical steroids and biologics are going to be a mainstay of treatment. And the earlier we operate on these patients, the better. Thank you.
Right. Alkis, thanks very much for the wonderful presentation.